We cover seizure disorders in great detail in the neurology lectures. What I want to do here is start off with a review of the must-knows from that lecture, seizures in general, and then go through a couple of diseases that are unique to kids. So let's start off with seizures first. And a seizure is defined as synchronous firing of the awake brain. This is okay to catch while someone is sleeping, but if this happens while the person is awake, that's the definition of a seizure. But you also want to be able to categorize seizures better. And you do that based on the presence of or absence of a loss of consciousness. If there is loss of consciousness, that is called complex. If there is no loss of consciousness, that is called simple. Then you also want to be able to identify it based on whether or not the entire body is involved, or the entire brain is involved, as a generalized seizure, versus only part of the brain is involved and therefore only part of the body is involved. That is going to be focal. Focal seizures are going to be called partial. So now you have a little grid that tells you a little bit of information about what you're actually seeing. A generalized complex seizure, you know, is grand mal. The person has a loss of consciousness, bowel and bladder incontinence, tongue biting, limb jerking, postictal state. That's what people usually think of when they think seizure. But you can have a loss of consciousness without the entire body being involved. That is going to be partial complex. Partial because the entire brain is not involved, complex because of the loss of consciousness. The same is true of simple. You could have a partial simple seizure, as indicated by the beginning of a Jacksonian march. That is, someone's hand starts to twitch, then their arm, then their whole brain goes. It is possible to only have the twitching of the hand. And while there are some seizures that are generalized and simple, when you see this in clinical practice, think pseudo-seizure. That is, they're faking it. Asterisk, though, in kids, you could have the atonic seizure, which you're likely not to see, where they have a loss of muscle tone, but not a loss of consciousness, and they need to walk around wearing football helmets. So now that doesn't always mean they're faking it, but that's how I want you to see seizures. And we have to decide, is this just a seizure? That is a one-time off thing. And if you think that's the case, you have to know why it happened. And that's the vitamins mnemonic we talk about in greater detail in that neurology lecture. And it's seizure versus epilepsy. Epilepsy is recurrent disease. The idea being, if it's just a seizure and you fix the cause, they won't seize again. But if they have a reason to continually seize, they've got epilepsy, now you need to treat them with medications. The diagnosis of a seizure is made with an EEG. And what you're going to see is that synchronous firing of the awake brain. But the EEG is only abnormal when they're having a seizure. So you may need to provoke them with rapid flashing light stimulus or some sort of sleep deprivation. When it comes to treating epilepsy, we're going to use the anti-epileptic drugs. And the good news is, for the most part, kids are equal to adults. So when it comes to just generalized seizure disorder or epilepsy, you use the same medications. And levetiracetam, Keppra, is what you're going to see most often used. It's clean, but it's expensive. So you may have backups, things like phenytoin, valproic acid or valproate, and lamotrigine. But then there are a few seizures that have different, very specific indications, and that is ethosuximide for absence and carbamazepine for tic douloureux, that is trigeminal neuralgia, which is effectively a seizure of the trigeminal nerve. To recognize these names, we're going to talk about ethosuximide in particular, see the neurology videos in medicine for more on vitamins and the medications you're going to use. So let's transition into talking about pediatric specific diseases. The first one being the febrile seizure. Now, kids can get febrile seizures while adults do not because the developing brain is more susceptible to seizure and fevers reduce the seizure threshold. Now, we used to believe that it was the rate of rise, but now we're not sure if it's the rate or the height of the fever that matters more. Now, this is not really a big deal because clinically you're going to do the same thing. Just when you hear it, it used to be the rate of rise is what mattered. But really, since fevers decrease the seizure threshold, it's probably both, and it's more about the delta. If it rises really fast, really quickly, more likely to seize. But what matters clinically is that when a kid comes in with fever and a seizure, you need to know what to do. Fever and a seizure, you're going to think jump right to LP, but you don't have to. The chances are that they've got meningitis is pretty low unless there are other clinical clues. So what we've decided is to say, hey, is this a simple seizure? That is, if it has all three characteristics, we'll get to what those characteristics are in a minute, then it is simple. If any one is absent, that's enough to call it complex, which is annoying because it's a different complex. Simple febrile seizures and complex febrile seizures are not the same as simple and complex in the way of loss of consciousness. What you're looking for to be a simple febrile seizure is to have 1 in 24 hours. That is, it does not recur. The duration is short, less than 15 minutes. And it must be generalized. I'm going to talk about that just a little bit. It sounds like simple febrile seizures are not that big of a deal. So you might think, oh, it's just one little foci. That's no big deal. One little focus of seizure, that's easy. So that must be simple. No. Must be generalized. That is, the entire brain must be involved, and it can't happen more than once in 24 hours, and it must be short. If you have any one of those absent, count it as complex. And here's the thing. If you're going to treat seizures, if they're actively seizing, you're going to use benzodiazepines to abort. It's true of simple or complex. It's true of epilepsy, and it's true of seizures. If they're actively seizing, give benzos. We talk more about status epilepticus in that neurology video. But for a simple febrile seizure, all you need to do is give antipyretics. And acetaminophen is a drug of choice. Never use aspirin. That's going to cause Reye syndrome. Now, it used to be that if we got their temperature down, we thought the seizures wouldn't recur. Turns out, if you control their fevers, they're just as likely to recur. But the acetaminophen is there to make the patient feel better because, after all, they're having a high fever. And you do not need any imaging. Because this is not epilepsy, you do not need any anti-epileptic drug long-term. Generally, it doesn't happen again. On the other hand, if it is complex, now you need to decide, am I going to do an EEG? Am I going to do an LP? Or am I going to do some sort of brain imaging? And now we want to do MRIs, not CTs, because CTs have radiation. And these are kids who are developing. You do the EEG if you're not sure if it's a seizure, the LP if you think it's meningitis, bulging fontanelles, rash all over, or an MRI looking for something in the brain if you don't think it's the other two. And because this is complex, you are going to do some sort of imaging, as we just discussed, and they're probably going to be put on anti-epileptic drugs. Because it's not the fever that did it, they happen to have a fever that elicited, hey, this kid's got seizure disorder, this kid has epilepsy. All right, so some other diseases we want to talk about are going to be things like infantile spasms, also called West syndrome. The patient is going to be very young, and they're going to have bilateral and symmetrical limb jerking. But it will not be generalized. And there will be no fever. So it looks like a seizure, but it's spasms. And this is why this is such a board favorite. The diagnosis of infantile spasms is made with an EEG. An interictal EEG will show hypsarrhythmia. You have to not know what that means. You won't have to look at a picture and identify it. But if you see the words interictal EEG, you know what you're talking about. Hypsarrhythmia, same thing. And the treatment is with ACTH. You think it's a seizure, you have these funky words for the EEG, you treat it with ACTH. There's no link between those, just memorize it, get the question right. Unfortunately, even if you do treat them, they're going to end up with some cognitive delay, some mental retardation. But infantile spasm, West syndrome, can actually be part of tuberous sclerosis. Tuberous sclerosis is a genetic disease. Technically, you can make this diagnosis at any age, but if you're actually doing physical exams or monitoring kids for seizures, you're generally going to see a kid who's less than 2 years old. And on the physical exam, you're going to see angiofibromas, or the ash leaf spot. Lights up with Wood's lamp. If you see those things, you jump right to tuberous sclerosis, you get some brain imaging. Or they're going to have seizures that gets you to get brain imaging for another reason, such as afebrile seizures or complex febrile. That is some reason to get brain imaging, because when you get that neuroimaging, either a CT or an MRI, the test should not make you choose between them. You're going to see the tubers. The problem with tuberous sclerosis is that the treatment is supportive. And much worse than infantile spasms, these kids are going to die young and have cognitive delay, mental retardation. The one you can actually do something about, though, is absence. And this is a big one because it bleeds into pediatric psych. Absence seizures are actually hundreds to thousands of seizures per day, where there is a loss of consciousness, but no loss of tone. It is now categorized as generalized, but it doesn't matter what you categorize it as because it doesn't tell you what to do clinically. It has a loss of consciousness, but no postictal state. So these kids are going in and out of seizures. They stay upright, they don't shake, and they're totally normal when the seizure stops. It's hard to identify. And so what you're going to get is a kid who has ADHD. The diagnosis is going to be made in an EEG, and this is why it's so important. What you're going to have is probably on the test a boy, because those are the ones who usually get ADHD, who are troublemakers. They can't sit still, they're all over the place, they never listen. So to the parent or to the teacher, they're a problem child. But to the child, what he's seeing are snapshots of the world that are not continuous. The teacher's over there on the right side of the room talking about apples. And then she's over on the left side of the room talking about a giraffe. And then she's yelling in the kid's face about a zebra. He's like, what happened? She just had a lecture about the alphabet, but he only saw A, G, and Z. So do the EEG to realize that they're having absence seizures, and you can treat these with ethosuximide, knowing that as backup, or if there are some sort of generalized seizures to go along with it, valproic acid. The good news is for absence, most kids will outgrow these. Okay, so if you want to know more details about seizures in general and status epilepticus, check out the neurology video. We reviewed a little bit how you categorize seizures and brought out some of the names you should recognize for anti-epileptics, knowing that a seizure does not need an anti-epileptic, it needs a benzo if it lasts more than 5 minutes to abort it, whereas epilepsy does require some long-term medication. Febrile seizures, all that matters, don't worry about the rate of rise or how high it gets, worry instead whether it is simple or complex. Simple febrile seizures, symptomatic control, let them go. Complex febrile seizures, got to do some sort of brain imaging, and chances are they've got an underlying disease, so put them on an anti-epileptic. Infantile spasms, interictal hypsarrhythmia, ACTH. tuberous sclerosis, ash leaf spots, seizures, tuber in the brain, not much you can do about it. Absence seizures, kid has ADHD, quote unquote, EEG shows a seizure, use ethosuximide. That's ped seizures.